Hey, it's Jessica DeMassa with WTF Health. What's the future of health? I am talking to the who's who of health tech and healthcare innovation. And today, please meet Chris Molaro. He is the founder and CEO of NeuroFlow, which is a behavioral health tech company that is working with payers, providers, and government organizations to help make sure that people who need mental health care aren't falling through the gaps. Now, Chris, I understand you are joining us from your brand new NeuroFlow corporate headquarters in Philadelphia, and we're going to find out all about that. But first, welcome. It's good to meet you. All
Thanks so much for having me, Jess. I'm really excited to be here.
right, so I know there's like a big party happening later, like, the launch of your new place, and I want to hear all the details about it. But before we get to that, I gave a little bit of an intro to what NeuroFlow does, but why don't you kick it off for us and just tell us about NeuroFlow? What do you guys do?
Happy to. I love to start off with saying what we're not, first of all,
Okay,
because there's
great.
a lot of behavioral health stuff out there. So NeuroFlow is not a telehealth company. We're not a telepsychiatry company. We're not delivering care directly to patients. We partner with a lot of those orgs, and we can get into that. But what we really are is we're a tech platform that integrates into care management systems and EHRs, electronic health records, to run data analytics to help assess populations and identify underlying behavioral health conditions. A lot of cases in physical health settings, we risk stratify them based on a bunch of different data points we collect to help navigate and coordinate those members and those patients to the right level of care. And that's where those partnerships come into play. And then we follow up with them and we automate those workflows so that patients don't fall through the cracks, and providers and clinicians are capable of doing the most effective part of their job, which is focusing on treating the patient and being supportive to their members.
This is so important because I think this is really addressing a major gap in terms of behavioral health care. And I mean, like you said, you guys I love how you started out telling us what you're not, because that really does help the aha moment of what you guys are. And this care coordination piece and helping clinicians understand who's at risk, what to do, where to send them, how to follow up with them is really important. So I understand that your platform has a couple different components to it, and I'd like to walk through some of that. So tell me a little bit about like the clinician side of this first. So like the clinical decision support part of it, because I understand from reading through the prep materials here that there's like the gold standard here is the psychiatric collaborative care model, which is very expensive to implement. And you guys have done much more than just simply digitize that. So pick up that story for us, please.
Yeah, absolutely. I think so. Just kind of foundationally, what happens today in a primary care clinic or a pain management practice? Hopefully they're assessing your behavioral health, right? There's depression assessments that exist out there, anxiety assessments, many of which are paper and pen. Maybe they're digital, but if I assess positively, or if Jess is my patient and I say, okay, you're struggling with depression, when I refer you to an outside therapist or psychiatrist, there's no visibility into, did you go to get that care? Are you getting better? And how is that impacting your physical care? We know that when someone has, say, diabetes and depression, they're worse off, they're more expensive, and it impacts both the mental and physical health. And so you're exactly right. The psychiatric collaborative care model is proven over 30 years, hundreds of peer-reviewed studies, randomized controlled trials that show its effectiveness to not only improve the mental health side of things, but to improve physical, like hypertension, depression, lower back pain, and down the list. The challenge is no one really adopts it. It's really expensive. It's complicated. It requires a lot of resources and time. And so that's where 30 years ago when it started, electronic health records weren't even really a thing. Today, with the analytics that we have, with smartphones, with computers, with the internet, we can use technology to scale that. And so we're not reinventing the wheel here. We're modular and configuring ourselves into the electronic health records so that those providers can adopt these care models and can do what's called measurement-based care with their patients.
That is, I think this is such a gap that needs to be addressed, particularly now as so many different clinicians are responsible for mental health. Like you mentioned, like primary care physicians or pain management clinics, or folks who are, treating people who have diabetes or hypertension. These are often, comorbid. There are often comorbid mental health conditions that follow along with that. And even it was just the other day they were saying, who was it? There was a government organization that recommended that all adults be screened for anxiety. And so now, yeah, what is that going to do now? So I mean, literally, all providers are starting to in some way be responsible for being a mental health provider, and the coordination of that is really important. The other thing I often hear when I'm talking to folks is that if you are one of those clinicians, you have no idea where to send people for help. So I understand there's like a referral component into the platform that you have with NeuroFlow. So tell me a little bit about the referral network that you've built and some of the companies that you are using to provide actual care services or to fill in some of those care gaps yourselves.
Well, I think so. Understanding kind of this notion of the step care model, and there's different types of care, different levels of care for different individuals. In other words, if you have mild depression, first of all, any listener that's out there, if you're honest with yourself, like who hasn't had their down days, especially the last 2 years during the pandemic, right? That doesn't mean that you necessarily need to go to a psychiatrist and get antidepressants right away. Maybe just some self-service type tools, meditation tools, or talking to a coach would suffice. Yet today, when I'm in primary care, the highest prescriber of antidepressants in this country are primary care providers. And they'll just refer you, say, here's a psychiatrist, here's a therapist, have at it. And that's where you get that bottleneck issue of these long lines to go see a psychiatrist, 30-day or more wait times. And in reality, most of those people may not need that high level of care. And so what we've done is the clinical decision support engine helps identify, if you have 1,000 patients, of those 1,000, who should be referred to that higher level of care. And then we have, APIs and integrations with those therapists and those psychiatrists to make that seamless handoff. A lot of our partners are the hospitals, health systems, or plans have existing networks and partners, and we'll plug right into them. But it turns out a lot of them don't have that, especially in rural areas, and if they do have networks, they don't have enough. There's a capacity issue. And so what we launched earlier this summer was our clinical referral network program, which takes telehealth and telepsychiatry partners that are best in class. They have a national footprint, so we could reach anybody geography-wise. They're across all different payers, and we can help plug in those patients into an additional resource like a teletherapy or telepsychiatry clinic that's in network for them, so it's a covered benefit, and help fill those gaps so that we could reduce those wait times and increase access to care.
Chris, I want to go back on something you said just a second ago. You were talking about how you guys help, point patients in the right direction, or help clinicians figure out how to point patients in the right direction. And what you said was that you guys look at a number of risk factors and then kind of decide which ones need what level of services, which is incredible. How are you guys doing that? Like, what risk factors are you looking at in order to do that type of stratification? Like, can you give us a little insight on how that part works?
Sure. So there's really two parts to that. So one, it's the standard of care that you would that occurs today. Another example of a place that we integrate with our OBGYN clinics for like postpartum depression or risks of postpartum. And all of those types of clinics, whether it's a PCP or OBGYN, are assessing for mental health, or at least they should be, when you're in the clinic visiting them. So the PHQ-9 is the standard depression assessment. The problem with that is if you're coming in for your annual wellness visit, you do that in the office, paper and pen, or they digitally input it for you, and then you leave, and there's a 11-month gap where they're going to assess you again. And what we know is obviously depression doesn't happen once a year. It doesn't happen, right? It could be what happens in 3 or 4 months when you leave the office, and now something happens in your life, and there's no visibility into that. And so the first bucket of our assessments is just doing those validated assessments, PHQ-9, GAD-7. We have 35 of them built into the system today that occur longitudinally. So we collect them in the office, but we also collect them when you're at work or in between your appointments and that sort of thing. What's really cool is now we collect a bunch of different type of data that is not replacing those assessments, but complementary to them. So if a patient writes something free-form text to their provider or a journal entry, we run natural language processing algorithms on that. So if someone says like, I'm in so much pain, I'd rather just die. Like, we're able to flag that account. We tie in with wearable devices, so we're tracking exercise level and steps over time, so we could see, Jess is normally like working out every other day and getting 10,000 steps, and that's dropped off. Like, that's a data point to indicate maybe something else is going on. So there's all these different data points. We have partners now that are doing voice analytics that we could integrate into there. And what's really neat is that this is data that we've all been collecting that's been out there, but hasn't been used to triage patients for mental health risk factors. And in many cases, it's not to the point where it's diagnosable or it's like very severe, but you could kind of see it getting to that point, and we could be preventative, which ultimately helps people get better faster.
So what does the interface with the patient look like? So I think that's like the last piece of this. I know there's like a self-care component. So like, what is it if I am somebody who's seeing my OBGYN and they're like, Jess, we want you to sign up for this. So what does that look like? Am I signing up for NeuroFlow, or is it white label and it's the doctor's system that I'm interacting with? Like, tell me a little bit about that.
So I'm going to start off with, again, what we're not in this space.
Okay.
So we're not a mobile application.
Okay, good.
We have a mobile app as a feature, as one avenue to engage and collect this data, but we take what's called an omni-channel approach. So, there's a lot of people that either don't want to use smartphone apps or don't have access to data plans or smartphones. And so how do we connect with them? And so there's clinical workflows, there's SMS text, there's email, there's web-based versions. And so there's a number of different ways. We call it our Engage platform. The Engage platform communicates and engages with patients and members of health plans in between their appointments. And we're collecting data through, and then based on that data, we're able to supply them with self-help tools, educational type tools, and that sort of thing. Your question about how they're invited, it's all through the existing portals that exist. Like, if you're through a plan or a system, we're integrated with single sign-on capabilities. And the white label question is absolutely. So there are a lot of actually health plans and systems that want the brands to be differed, because there's the stigma of, well,
Sure.
I don't, Blue Cross, I don't necessarily want to be mental health, so they want NeuroFlow. And then there's others that want their brand from end to end, and we can white label it so it's a very ubiquitous type offering.
No, I like the optionality there. I also like how you're answering my questions with what you're not. I think that is great. It definitely clarifies things. All right, so tell me a little bit about health plans here in this, because we've been talking quite a bit about the clinician side of things, the patient side of things, and I'm curious about the health plan side. So how are you working with plans, and how is that different than the way that you're working with provider organizations or some of the government organizations that you're working with?
So I think it's interesting, especially as the world moves closer to value-based care and the providers and payers are coming closer and closer together. In some cases, they're the same organization, and so there's not much difference there. But in terms of like your more stereotypical health plan payer that has a network of providers, how do we work with them?
Sure.
There are two major ways that we work with them, and it's not all that different than providers. So you take the physician and replace the physician with the payer's care manager. So imagine if you have, you're a multi-chronic condition member that has diabetes and hypertension. You're going to be enrolled in a high-cost care program to try to manage those costs and get you the best care as a member. What about those members' mental health, though? Those care managers on the medical side are trained to deal with diabetes and hypertension, but in a similar way to the primary care physician's not trained on mental health, neither is that care manager. And so we integrate into that workflow very similar to how we would with the primary care physician or the other medical specialties, just at the payer level. The other payer workflow that we work with is to complement their claims data, right? Claims data is tremendously powerful. We know it has a lot of precision, predictive capabilities and so forth. The challenge with it, though, is if Jess, you show up to the ED, they're not going to know that for 3 months when they get that claim, they process it, and then it's too late. So what can we do to help be preventative, to keep you from going to the ED and get the right care before it reaches that level? And so we're launched in that situation in a payer to be, to to be a member benefit that makes different tools available. And a lot of these plans already have investments in wellness tools or teletherapy partnerships. And so that's great, because layering us in there allows us to be a force multiplier to those existing investments. We're able to ensure that the right members are getting to those existing investments, and then the other members falling through the cracks.
What does that look like from the case manager side or the clinician side? Like, what do they see? Are they like inundated with alerts then? Because I mean, I know those people, especially the case managers in a health plan or even a provider, they inundated with information. I mean, we always hear about the burnout associated with an EMR. I mean, you mentioned earlier, integrated in if you need to be, but like, what does it look like from the other side, from the person who's trying to make sure that none of these people who need mental health services are falling through the cracks? Like, what are the alerts? What is that? Say a little bit more about how that information gets to the person who's responsible for directing the person in need with the information about where they need to go.
Jess, so glad you asked the question about, are they inundated with data? Because the answer is no.
What you're not inundating with data.
Well, I mean, frankly, we wouldn't get the adoption or the usage.
Right.
I mean, I feel for physicians when they're asked to see, a patient every 10 to 15 minutes, and they have to do a bunch of different things. The last thing they need is another platform with more data that just takes their time away from the patient. So what we try to do is make it, crunch all that data and then make it in the bite-sized elements that they could just take it really quickly. Like, what do I need to get from this? How is your depression impacting your hypertension so I could treat you more effectively? And integrating that into their existing workflow, so they're not having to log into NeuroFlow to do that, right? So these kind of bite-sized snapshot pictures at the moment that you need them, not 24/7. And there's also roles and permissions. So a primary care physician might not need to see as much of the information as a therapist that's actually going through treatment with you and so forth. And so we're able to have filters depending on the type of user you are on the clinical side, depends on the type of data that you're going to get to see. And then the last thing is, I think that this is really interesting. There are these urgent alerts, and people are always concerned with, like, I'm going to assess more people. And if I assess more people, I know I'm going to have more issues. And some of those issues might be suicidal and like rise to the level of and self-harm and so forth. And for the longest time, we were getting the answer of, because of that, we don't have the resources, so we can't do this. Even though we know it's the right thing to do, we don't want to do it because we're going to create more of a problem. And I felt for health systems and plans that said that, but it was still frustrating to us because we're like, oh, it's the right thing to do.
Yeah.
So about a year and a half ago, we launched a service called Response Services. And what that is it's a clinical team that we staff that will monitor the platform 24/7 for the plan and the providers, that if someone is flagged as urgent for self-harm, we'll do the outreach to them, not to do care for them, but to do the outreach to them to make sure that they're doing okay, and then get them to that right level of care. And so that has worked really great from a partnership standpoint. It's mitigated the risk for them, and it's been able to get us direct communication with those patients.
Chris, I love that. That is really smart. I mean, and I can see where, a lot of health systems or, I mean, even like a health plan, if you're a case manager, a care manager, it's like, yeah, that is intimidating to be put into that situation. And so to remove the burden of that, but still be able to provide that level of oversight and care to the person who's in need and in danger at that point. That's really incredible. I love that. Awesome feature to include. Okay, so I have to talk about the unfun stuff now. So how do you guys make your money? What's your revenue model look like? I mean, are you like a per member per month type of thing? Are people paying for seats on NeuroFlow? Like, tell us how you guys operate in the market.
Sure. I mean, yeah, I guess one of those things, right? The necessary evils to get to do all the fun stuff. You have to make money. So well, I think first it's important to say that our model would not work if we weren't demonstrating ROI, outcomes ROI, savings, and revenue ROI to our partners. Otherwise, it's not sustainable. And so the way that we structure our partnerships is twofold. So we're talking about the clinical side of the platform, we call that manage, and then we're talking about the patient and member side of the platform, we call that engage. and they're modular. So we have some partners that use Just Engage, we have some partners that use Just Manage, and then you could obviously roll up the whole platform. And so Manage on the clinical side is a license fee for number of providers and care managers that you have on it, and then Engage is a PMPM for the volume of eligible members or lives that you have in your population.
Oh,
But
I
it's
like
not,
that. I like the build your own and then the kind of duality of the model to support that. I think that that's really smart. So talking more about the business, I mean, you guys have raised $32 million total. You just closed a Series B in January of 2021, so last January. Magellen led that. 20 million. I mean, so you guys are really well funded. You're on a trajectory for growth. Tell me a little bit about that. Like, talk to me about the business. I mean, obviously, the spiff new headquarters behind you. We're looking at that office space. I mean, maybe start there. Tell us about the move into the Philadelphia city center. I mean, that's where you guys are headquartered at now. I mean, tell us a little bit about this new space and like kind of what it indicates for where you guys are at with your growth.
well, it's been, I think humbling is the right word. I mean, we've been in business for a little over 5 years now. We got started in Philadelphia. I was at the Wharton School for my MBA. My co-founder, Adam, was getting his PhD in Penn Engineering. And we met in a grad school program. And so we got our roots are here in Philly, even though I'm from New York, so I'm a New York sports fan.
Okay, all right. Well, thank you for clarifying. Chicago girl here, so yeah, I hear you.
But our business roots are here in Philly. Like our initial employees are here, our customers are here, our earliest investors are here, and our original like office spaces were here. And so as we've grown and matured, it's been important for us to keep at least some of our roots here in Philly. Now we're a little over 100 employees. Maybe 2/3 of them are relatively local to Philly, but the rest are all over the country. And for us, when we're thinking about office space and so forth, obviously the world is a lot different today than it was 2 years ago, pre-pandemic. And we recognize we have a very flexible work environment. There's no mandate to have to come back to the office. But what I'm a big believer in, and I guess this is debatable, in order to really innovate and to have trust with each other and relationships, you have to have a place where you could come and call yourselves a team and develop those relationships. And so that was really important for us. We just moved into it's at 1601 Market Street. And it's a place where not only the team comes, but we bring partners, we bring clients, we bring prospects. And it's we've only been here for a month, but it's really been this kind of center of our universe. And then we can, some days a lot of people are here, some days not a lot of people are here. And we have that flexibility built into our model. And what is maybe really exciting, and a smaller note, I said our original office was here in Philly. So we moved back to Center City at 16th and Market, next door to us, and you could see the office from our current office was an old original office we
Oh,
had,
how
which was like,
cool.
yeah.
So you look back at where you started. That's so great. You moved back to the neighbor. You got successful and moved back. I love that. That's great. Well, congratulations. I see a lot of people walking back and forth behind you. So it looks like a very buzzy, busy space. That's exciting. All right, wrap this up for us and tell us what's next for you guys then. I mean, it's like obviously the new space is indicative of your growth, and it's particularly exciting for me to hear this at a time where a lot of people are very worried about health tech companies and what's going on. So it's nice to hear that you guys are doing well and you're growing into some bigger space and looking back at the space that you came from the windows. It's very cool. But tell me about NeuroFlow and what's next. I mean, you're still obviously well funded. Like you said, Magellen led that round. That's a great endorsement by a wonderful company in the space. So I mean, tell me what's on the horizon for you. I mean, what are you guys looking at next in terms of evolving the product and also in terms of scaling up your client base?
Well, we could start with the product. So the product side, I think, is we're finally at a point where I think if we just stopped doing product development and just maintained where we were at, we'd have a very competitive product moving forward. Obviously, I don't think that's a winning equation, though. I mean, that might last us 6 to 12 months. We have to continue innovating. And the scientist in me wants to continue always like tinkering and looking at different data sources we could bring in. So we're doubling down on our interoperability strategy, APIs, being really connected and ubiquitous throughout the system. and then being able to collect as much data as possible so that the providers that we're assisting can really do their job more effectively. So from a product standpoint, there's no slowing down on that side, doubling down. And then from a sales standpoint, our sales team is relatively small. We got to where we are today, with 50 plus customers. We have 15 million lives on the platform, with a sales team that I could count on one hand.
Wow.
And so 2023 is going to be about growing and scaling our ability to be able to be helpful to more health plans, more systems, connecting with the two of them, right? That interoperability theme again. And I think, ultimately the goal here is, and this is why I love healthcare, is that when you do good, you can do well, right? And so if we're at 15 million lives supported on the platform today, that's definitely a lot compared to where we were. But when you think about it, that's just tip of the iceberg in terms of there's 300 million people in the US, and all of them have some sort of mental health issue, even if it's resiliency and wellness. And we still have a lot of growth that we feel there, and a lot of people that we can help. And we're just talking US now. There's international expansion plans and so forth. We just converted the platform to Spanish, so next year will be a big growth opportunity with that. And I don't know, we'll see. We'll see each other at Health though in a few weeks, hopefully.
Yeah, so we'll definitely check back in with you at Health and hear how things are going, in a different capacity there. But, it's been great to speak with you, Chris. Thank you so much. I mean, those sales guys deserve some shiny offices in this new space that you have. So I'm going to advocate for them to get that.
They'll be happy to hear that.
Okay, good. Well, Chris, thank you so much for joining us. That's Chris Molaro, everybody. He's the founder and CEO of NeuroFlow. Again, we're talking to him from his brand new corporate headquarters. They've been there for 30 days. They're looking at the old office space they moved out of way back when, 6 years ago or 5 years ago. And now here they are. So thank you so much for joining us and telling us about what you guys do. It's been a pleasure to speak with you, and best of luck in your new home.
Thanks so much, Jess. Appreciate it.
All right. Well, if you want to check out more interviews with the who's who of health tech as they are changing the way that we do healthcare, head on over to my YouTube channel. It's youtube.com/WTF Health. I'll talk to you guys real soon. Thanks again, Chris. Bye.